Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. George Demetri of the Dana-Farber Cancer Institute in Harvard Medical School in Boston, Massachusetts, and Dr. Alexander Drilon of the Memorial Sloan Kettering Cancer Center in New York City. They will be discussing the mechanisms of acquired resistance to first-generation TRK inhibitors, along with emerging efficacy and safety data on second-generation TRK inhibitors that can overcome resistance to the first-generation therapies that are currently approved for patients with solid tumors. This episode is part of a larger educational program titled The Expanding Clinical Application of TRK Inhibitors in Cancer Care, a podcast series. For more information on Dr. Demetri and Dr. Drilon, along with a link to the complete program, including a downloadable slide set covering the content of this podcast, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hi there, I'm Alex Drilon. I'm the Chief of the Early Drug Development Service at Memorial Sloan Kettering Cancer Center in New York.
Hi, I'm Dr. George Demetri. I'm a professor at Dana-Farber in Boston.
All right, George, we've come to the final episode where we're going to discuss whether or not there are options for patients who have already had targeted therapy with a TRK inhibitor and have progressed. So what do we know, first of all, about mechanisms of resistance? In simple terms, how do these cancers learn how to outsmart the first generation pills that we throw at them?
I think we've learned a lot from other kinase-driven diseases like EGF receptor mutant lung cancer, like KIT-driven GIST. We certainly know that these are the prominent and dominant drivers. And that's true with the NTRK fusions, right? Once you shut down the TRK enzymatic activity with a TRK fusion inhibitor drug like larotrectinib or N-trectinib, then you get a long period of control and ideally a significant decreased tumor size, maybe even a complete response, which is what we see commonly in the most sensitive subtype, the infantile fibrosarcomas. But over time, especially for the more genomically unstable adult cancers, these tumors are likely to shift their genome, and under the selection pressure, we see new mutations pop up in the TRK fusion gene. And that's just what we see with imatinib resistance and just what we see with your expertise in lung cancer with things like EGF receptor mutations that pop up that are not treatable with the first generation EGF receptor inhibitors. And those would be called on-target resistance. And your group at Memorial Sloan Kettering has been key in identifying many of these. Maybe you want to talk about them because they go by clever names like gatekeepers and solvent front mutations and things like that. Why don't you explain what all that means?
That's right. We'll try to simplify, but I think, the essence of this is, as you mentioned, these tumors were born with a dependence on NTRK, and they try so hard to go back to reactivating NTRK that they find ways to in a way, kick these drugs off of the binding site of these TKIs. And so what happens with these mutations is that you have a change in an amino acid, for example. If we think back to EGFR, it would be T790M, where you go from a T to an M or methionine. And there it's exactly the same nomenclature, actually, for NTRK, where you have mutations like G623R, for example, or G595R, depending on the NTRK fusion, but it's functionally the same. You may have a bulkier amino acid with a different charge that inhibits or prevents larotrectinib or entrectinib from locking onto the kinase and shutting down oncogenic signaling. And the clever names are simply geographic. It's where these occur in the kinase. So there's the solvent front, there's the gatekeeper, and then you have the XDFG motif. But I think these are all convergent really in trying to prevent these first generation drugs from binding.
I think you gave an important secret away there that people can figure out what's going on by these weird names like, G595R. So the G got replaced by an R. And there's a single letter amino acid code that's written on the back of every medical student's hand at some point. So that's really easy to understand, that the mutations, even though we're anthropomorphic, and you said these tumors' genomes are trying to knock the drugs off, I personally think it's just more stochastic. It's just random noise. But like you say, if you put a monkey in the room with a typewriter for a few million years, eventually it'll type Hamlet. And that's exactly what's happening here. These tumors are randomly shifting their genome, but like COVID, they're finding ways of getting away from, in that case, the immune system, in this case, from targeted therapy. So because we understand that, how do we solve for it? Have we been able to solve this resistance issue for on-target resistance?
Well, we thankfully have wonderful chemists. And these chemists have cracked the code and figured out ways to make newer tyrosine kinase inhibitors. We'll also call them next generation, although we should name these generations better over time. Perhaps second generation TRK inhibitors that avoid the penalties of these amino acid substitutions that we talked about. And the design is clever, actually. If you imagine that a gatekeeper mutation presents sort of a goalie that's blocking the gate, what the chemists have done with these second generation, next generation inhibitors is design them to be much smaller, so that it's easier for them to zip past the blockage, zip past the goalie, and re-engage the kinase domain and shut down oncogenic signaling. And there are two major ones that are already in clinical trials. One is called selitrectinib, and it was named that because it's a selective next-generation TRK inhibitor. And the other one is repotrectinib, which is similar to entrectinib in that it's a next-generation inhibitor that inhibits other things like ROS1.
And you say it's a smaller molecule. Have you seen in your experience any side effects? Because if it's slipping between the goalie's legs into the goal of the target, how about other targets?
Yeah, it gets to the other major property of these next generation inhibitors. Beyond them being smaller, they also, if you will, hug the kinase much more tightly. And in scientific terms, that means they're much more potent at inhibiting TRK A, B, and C. And because, in a way, you're pounding TRK a little bit harder, you do see some side effects much more prominently. And it's easy to remember because they're the exact same side effects that we might see at a lower frequency with the first generation drugs. They're dizziness, ataxia, weight gain, paresthesias. And one thing that I don't think we mentioned is that there's a phenomenon of withdrawal pain when you temporarily or permanently discontinue these inhibitors because of how the TRK inhibitors rewire our thresholds for feeling pain.
But I will say I've had some experience with these second generation drugs as well to reverse resistance. And I've been very impressed with how effective they can be and actually how well tolerated they are. Our patients have had a little bit more of these side effects, like especially a little bit of the dizziness, because ataxia sounds really scary. But the ataxia or the dizziness, some balance issues, I've found that to then go away. There's a tachyphylaxis in medical terms. You get used to it after a few weeks or months, and then patients can go back to their normal lives and actually tolerate these drugs quite well with durable benefit. Now, both these drugs are not FDA approved, and there are probably more that our chemists are whipping up in the laboratory that are going to come. But just like we see with EGF receptor inhibitors, just like we see with KIT inhibitors and GIST, we have opportunities here in the research to really give patients durable benefits over time. And I don't know about your lung cancer patients, but some of my sarcoma patients are now on second generation drugs for years, which is unheard of.
Oh, these drugs, the second generation drugs can work very well. And it's not just lung cancer. I've seen patients with GI tumors, I've seen thyroid cancers benefit from this paradigm of sequential targeted therapy. We're spoiled again in the lung cancer world that we've seen this with EGFR and ALK, where you start with one pill and then you can reach for another pill after progressive disease. And certainly we're seeing that in the NTRK fusion positive space that it's a paradigm that works. And while these are only on clinical trials now, these trials are actually geographically at many different sites around the world. And if you have a patient, it would be recommended to try to seek out one of these programs if there's one that's near you.
And Alex, like we've said before, we've learned a lot from EGF receptor mutant lung and other kinase-driven diseases. We certainly know that there are other pathways to resistance other than EGF receptor resistance. And that's certainly true with TRK fusion patients, that there can be so-called off-TRK target resistance mechanisms. Do you want to comment a little bit about some of the ones you've seen in that bin?
Of course, and whether or not be my sort of romantic and anthropomorphic view of the acquisition of these are truly actually, I do think that there's a stochastic process here. Some cancers will acquire dependence on other genes. So if originally a cancer was dependent on NTRK, a concrete example would be tumors where they sort of phone a friend and say, well, let's rely on MET. Or let's rely on KRAS. And you'll remember these genes as bona fide mediators of oncogenesis in other contexts. And it's interesting that these cancers are, sort of phoning the same friends or mediators of cancer that we see in other contexts. And how, this might pop up on a molecular report would be that you might see something like a new MET amplification that wasn't there. Or perhaps a new BRAF V600E mutation. And there is proof of concept that there's something that you can do about, some of these cases. There have been patients at our center who have developed a MET amplification where we added a MET inhibitor to the TRK inhibitor. And there also have been cases where we added, in the face of the acquisition of a BRAF V600E mutation, a BRAF inhibitor to an NTRK inhibitor. But to be clear, there aren't yet clinical trials that are specifically directed at off-target resistance, but at least we've shown that this paradigm of combination therapy can work in some situations.
And in the colorectal space, an open secret is that a lot of the NTRK fusions actually occur in the setting of a very high tumor mutational burden. And so there's an opportunity, if there were to be resistance, for immunotherapy to come in. So I think there are many, many different ways in which research is going to take us so that we can really help these unusual patients with TRK fusions to live really high quality and much, much longer lives than before these drugs were available. Well, Alex, it's been great talking with you today.
Likewise, George. This was fun.
Thank you very much, Dr. Demetri and Dr. Drilon, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, The Expanding Clinical Application of TRK Inhibitors in Cancer Care, a podcast series, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.